Hi again, it's me. I've just spoken to Dr. Saab from CRGH in London and Canterbury. He should be joining any second now. We've had some serious technical issues tonight, so apologies everyone. I know it's such an important topic, male fertility or male infertility. So let's see if he's here and we can take it from there. I appreciate your patience. Here we go. If you have any questions, please ask. Good evening, Dr. Saab. How are you?
Hello, good evening, Denise. I'm so sorry for you and for everyone who's following us today. Basically, I had some technical issues. I'm terribly sorry for everyone.
No problem at all. I did introduce you the first time round. So for anyone who missed that, I said that, of course, you are the Deputy Clinical Director for CRGH in London and Canterbury. And am I right in thinking that you've been there since 2007?
That's right. I have been at CRGH since 2007, and I also am an academic. I'm a senior clinical lecturer at University College London as well. And I'm interested so much in research. I have lots of publications, mainly related to treatment of the infertile couple, recurrent implantation failures, and immunology as well.
Mm-hmm. Great. Well, tonight we're going to be talking about male infertility or male fertility. And I've explained to people just now that that's very close to my heart because my husband is infertile due to a genetic condition, Klinefelter's. So should we start by talking a little bit about initial tests?
That's many thanks for inviting me, Eloise. And this is a very, very interesting topic because I have to admit, being a man myself and dealing with the infertile couple, is that we always shed light on investigations, tests, treatment for ladies, and unfortunately we forget sometimes about men. They are like lurking there in the background or only supporting their partners. So basically male infertility accounts for approximately, so if you want to simplify matter, it accounts for 40% of the infertile causes, 40% are female infertility, and 20% are unexplained. And I have to admit, the more we know, and with the more we know in research, this 20% is most probably going to be divided evenly between men and women. So we end up having 50% male infertility, 50% female factor infertility. Yet, basically, we shed most of the light on ladies, on ladies, on ladies. So going back to your question, remind me, Eloise, you were asking about the investigations, isn't it?
Yes.
So when it comes to the investigations for the
I've got a really, really bad cold. I'm having a bit of a coughing fit, so bear with me.
So basically, when it comes to the male factor infertility, when it comes to the investigations, I will start by saying that the basic or the ABC for infertility is checking on the men's side a semen analysis or a sperm test. And mainly in the semen analysis, all people who do the semen investigation will receive a piece of paper with lots of numbers and figures there. To simplify the matter, what mainly we look at is basically three important parameters. The density or the concentration, because every man in every single ejaculate, men in general ejaculate somewhere between 300 to 500 million per ejaculate, while a normal density is somewhere between 15 million and more.
Wow.
So we look for the concentration, we look for the motility or the mobility of the sperm, and a good motility in general is approximately 45% or more. And in the motility, if we want to complicate matter a little bit, we want the sperm to be moving in the right direction, or the progressive motility, and the normal forms as well. So we look for these three basic parameters when it comes to the semen analysis. Going back to your question, so we start with the basic semen analysis, which unfortunately, we have been stuck doing semen analysis for the last 2 decades as the main thing to investigate men. While in case the semen analysis is abnormal, semen analysis mainly reflects quantities, they are numbers. But up until recently, we have no investigations for the quality, up until one of our colleagues, Professor Sheena Lewis, and who's one of the pioneers. There are lots of pioneers who check for sperm DNA fragmentation, which is one of the tests that will check quality of the sperm too. So on the sperm, we can divide the quantitative test as being the semen analysis and a qualitative test. Examples of the most commonly used these days is a DNA fragmentation. And if the sperm count is very low, like some terms called oligospermia, where the count is low, or azoospermia, where there's absolutely no sperm, then we start investigating some hormonal blood tests for men, because we men and women, we share the same hormones, but they do differently.
Mm-hmm.
And we also check chromosomal analysis to check, for example, as you mentioned, Klinefelter is picked up with a chromosomal analysis. And men with no sperm, we check them for cystic fibrosis, for instance, and something called Y chromosome deletion. These are the basic investigations in addition to hormonal tests when it comes to the investigating the sperm.
And do
Or
you
male
think that
factor.
sometimes couples may leave it quite late to have the man tested?
I cannot agree more. I cannot agree more, because as I started by mentioning, is that unfortunately, mainly since the fertility industry is run by gynecologists, so indirectly we start taking the history from the lady, and instinctively speaking, it's the lady who's going to carry the pregnancy, it's the lady who's going to have the echolation. So we forget sometimes the men, and we start investigating at a little bit later stage. While also, just apart from infertility, for instance, when it comes to miscarriages, for years we used, unfortunately, to blame eggs, blood clotting factors, uterine problems, while right now there's enough evidence to suggest that men with elevated DNA fragmentation, their partners will be at a high risk of miscarriages.
Really?
And that's quite important. So it's not only a matter of fertility, but a matter of also keeping the pregnancy. So I cannot agree more, which is, I like these basically, interviews. Also, the media is shedding more light on male infertility right now, which is helping things basically to be guided towards the right way, investigating men and women at the same time.
Absolutely. Yeah, I think that's great advice. I mean, I've just been explaining to people that my husband had micro-TZ or micro-tessie because he has euspermia. How often do you see a man with zero sperm?
Remember, out of those men, we said that around 40 or 50% of the couple will have infertility, means male factor infertility. And among those, sometimes it might account, it depends on the kind of population that you see, but it can range somewhere between 5 to 10%, ranging between oligospermia to complete azoospermia. And azoospermia, you can understand how frustrating. I'm sure you have, obviously have been through the experience before, Eloise, how much it's stressful for the ladies and for men specifically to discover after their partners have been through sometimes months, sometimes years through investigations, to discover at the last minute that there's no sperm in the ejaculate. And this can be frustrating because unfortunately to this minute, we still consider male infertility as a stigma, as a taboo. We are raised from school onwards, from society onwards, that men has to be tough. They are the saviors. They are the supporters for their partners during the treatment. But we never shed light on men as playing a role in the fertility, in the infertility as well. So azoospermia do account for around 5 to 10% in that subcategory of fertility issues.
And he obviously found it very demasculating and a very difficult diagnosis to have. For people who do have sperm, but perhaps, it's not particularly good and doesn't have the amount you'd like to see or the movement you'd like to see, what are the lifestyle choices and changes that people can make to improve the sperm?
Perfect. So this leads me to discuss the second point, which is the treatment for low sperm or treatment for male factor infertility. And it's a spectrum. We shouldn't only focus on the medical part and the treatment, because lifestyle also plays an important role in that. When I say lifestyle, we check what the WHO has been defining as what is the normal semen count. You discover that the normal reference range has been dropping with time. So unfortunately, the 21st century is not the best time for the sperm. It is worse than the 20th century, and the 20th century is worse than the 19th century. And there are quite few lifestyle changes, like, for instance, smoking. The effect of smoking on the sperm is insidious. It does, increase with time. The effect of also medications, the effect of other lifestyle changes like body weight. Sometimes by losing body weight, we might improve. Alcohol intake, decreasing alcohol intake, caffeine, by decreasing caffeine, all of these will improve the outcome. Exercise, anything that increases testicular temperature has been associated with a negative impact on the sperm, because spermatogenesis in general, for it to happen, it will happen at 3 to 4 degrees lower than body temperature. So anything that increases testicular temperature, like saunas, like jacuzzis, like tight underwear, like cycling for limits, has been associated with a negative outcome on the sperm. So adjusting any of those lifestyle will improve, obviously. Right now, nutrition-wise, we would like men to make sure to have a balanced diet. They're 5 a day of fruits and veggies, decrease their saturated fat. Although we will reach there in a second that might not sort the problem 100%, but all of these are factors that will contribute to a better quality sperm. It's common to ask men to take vitamins, including antioxidants, for example, like vitamin C, like vitamin E, taking coenzyme Q10, taking zinc. All of these parameters all of these lifestyle changes will improve semen parameters with time.
I was going to ask you about male fertility supplements because, again, there's a lot of focus around what the woman's taking. So are you an advocate for looking at supplements as well for men?
Of course, of course, of course. At the end of the day, whether with fertility or with any other field of medicine, we are what we eat. So for ladies, it's important. Obviously, it's beyond the scope of today's discussion, like the folic acid and the rest. But for men, there's enough evidence in the medical literature to suggest that antioxidants, which will prevent oxidants, oxygen-free radicals, are toxic substances that all of us produce on a daily basis. They are harmful to all the cells in our body. Specifically in men, it's harmful for the sperm. So anything which is known as antioxidant, when it comes to eating, anything that is lots of greeny stuff and so on, vitamin C obviously will decrease the oxidative stress on the sperm, improving the outcome as well.
And are you able to say which supplements might be good to take, or does it down to the nutritionist?
Basically, obviously, the vitamin C, vitamin C, vitamin E, vitamin D is quite important. I always tell, specifically during the current atmosphere with COVID-19, I always put all my patients on vitamin D because it's good for both. Vitamin D is good for fertility. Vitamin D is also a good supplement for COVID. And so vitamin C, vitamin D, vitamin E, selenium and zinc, and coenzyme Q10. These are the buzzwords when it comes to the vitamins and the vitamin supplement that has been shown based on some studies saying that it does improve outcome. Specifically, it improves motility and improving normal forms.
Okay.
Having said that, since the topic is also, Louise, I don't want to know whether you mind me mentioning, because we are discussing that in the middle of a massive pandemic, which is the COVID, there's actually in the Lancet, there was some evidence suggesting that COVID-19 affects semen parameters, and most probably we will start seeing more and more effect of the COVID pandemic in the coming years. It is interesting that COVID is not the first virus known to humanity to affect fertility. We are all aware about mumps, which is one of the viruses that affect fertility. Studies is published in the Lancet in a very renowned journal saying that COVID-19 will affect spermatogenesis, which is the division of the sperm. But obviously it will take us years, if not months, to know if this is reversible or not.
Yeah. It's quite scary, isn't it? And there's really nothing that people can do about it except for taking precautions.
Precautions and hopefully the vaccine, and we'll see how it goes in the coming few months.
Absolutely. And we've had lots of questions, but please could you start to talk a bit about medical and surgical treatment options?
Perfect. So going back right now, so we discussed the diagnosis and we discussed lifestyle. Medical treatment is quite important for men. Not all men, I have to admit, will benefit from medical treatment, but some subcategory of men will benefit. Starting where I said that the men and women, we share the same hormones. For instance, FSH, which is a hormone that stimulates eggs in ladies, will stimulate the formation of sperm in men. So in men who have oligospermia or a low sperm count, and in a specific subcategory of those men where the hormones are low, specifically if testosterone is low, for instance, taking pills of Clomid, or clomiphene citrate, or taking some injections of hormones given exactly they are exactly the same hormones given for lady during stimulation, can improve outcome when it comes to sperm count. Specifically, sometimes they are given by the urologist before they do the surgical treatment to improve the likelihood of finding sperm.
That's what my husband had. I had to give him those injections.
Which is basically for men, just because sometimes it's a very common question that we have asked. So can I start the injections today, and my partner, can she start the stimulation tomorrow morning? And just when it comes to the normal physiology, that it takes approximately 3 months. It's around 70 days, a little bit more than 2 months, between 2 to 3 months, for the sperm cycle to be completed. So it's not uncommon, for instance, for men to take those medications, and they will be advised to have the procedure 2 to 3 months down the line in order to improve the likelihood of finding sperm.
Mm-hmm. Yeah.
Going through the surgical part of the treatment, which was your your next question, Louise, is that obviously we would always prefer if we can find sperm in the ejaculate. If we don't find sperm in the ejaculate, we have to start seeing where we can find sperm. We start going backwards. Sometimes we might find sperm in the bladder, which finds a little bit weird, but there's a specific subcategory of men where they ejaculate, but this is what is known as retrograde ejaculation. So the sperm, instead of going to the outside through the urethra, it goes into the bladder. And in that case, we try to retrieve the sperm from the bladder. Mm-hmm. If we are unable, then we go obviously to what is known as the surgical sperm retrieval. And attached to the testes is a small tube called the epididymis. And attached to the epididymis is a small tube that called the vas, or the vas deferens. We always try to see if we can find sperm in the epididymis to start with. If not, then we go to the testes. There are different medical terms that I don't want to confuse everyone with, like MESA, PISA, microTZ. All of these are different terminology for different surgical techniques that are used to help in assisting getting sperm from the testes. For instance, when we add micro, like a microTZ, that means the surgeon will have to use a microscope to help in dissecting the tubules in the testes a little bit more carefully.
Mm-hmm. And what are the success rates for these operations and procedures?
It depends on the cause. So in most, I have to say, in most of the cases, we will be able to retrieve sperm. In some cases, specifically when the hormones are quite high, when there's testicular failure, or when the testis is not producing, this will decrease the likelihood of finding sperm. And in that case, basically, couple will be counseled or advised to proceed via the sperm donation route. But the percentage will depend on the cause, while in the vast majority of cases, we will be managing to retrieve sperm. Yet, unfortunately, that doesn't happen for everyone. And in that case, we have to go through the sperm donation route.
And if everything is okay with the woman, does that obviously help with the success rates?
Obviously, because it takes the sperm and the egg. So in the equation of having a child, if we want to simplify medicine, the ingredients are a good sperm, good eggs, and a good environment, which is a good uterus, where the embryo is going to be there for a period of 9 months. Mm-hmm. So if we are starting from good quality eggs, because if we look at the egg, Louise, and the sperm under the microscope, the egg is by far a larger cell compared to the sperm. And what's interesting from the scientific point of view is what happens in the embryo. The first 3 days of embryo development depend on what's already in the egg. And the sperm will be contributing, but not majorly, because from day 3 onwards, the embryonic genome will start being expressed. And for this reason, obviously, if we are starting from good egg quality, it will help the sperm, to put it in a simple way, in creating a good quality embryo and a better outcome on the long term.
And if you were to retrieve sperm surgically, would it be preferable to use it fresh?
Very good question. Actually, it's a very common question that we have asked. The answer is we always prefer fresh if we can. By that, I mean that we try to synchronize the cycle to have the men's sperm retrieval on the day of egg collection. We have to be logical. Sometimes it might not be feasible, in the sense that sometimes if we have any doubt that the likelihood of finding the sperm might be a little bit on the low side, it's not also a wrong decision to proceed with sperm freezing and then defrost on the day of egg collection, because most of the studies have shown similar outcomes between fresh and frozen. But when it comes to the logistics, if we can retrieve fresh sperm on the day of egg collection, we will do that.
Mm-hmm. Yeah, absolutely. Because for my for my personal situation, I had IVF at the same time, so that if they were to find sperm, they had my eggs fresh, ready to go.
That's to be honest what we always aim for.
Right.
What we always aim for. Obviously, sometimes I'm just thinking out loud right now. Some ladies will say, because it's always important to have a backup plan just in case. Although we go very positive to retrieve sperm, but it's always important to have a contingency plan or to be prepared of the outcome. Assume we did not retrieve sperm, then what can we do? We can either freeze the eggs, or if the couple are already have prepared themselves with the donor sperm to be as their backup plan, this will be a contingency plan. If we freeze eggs, then the gentleman might elect to repeat the procedure a few months down the line after taking more medications or changing lifestyle to see if the outcome is better.
That's a good question. Is it likely that the surgery might be better a second time round?
It is again, when it comes to that, it goes back to the cause. Most of the time, I can say that if we don't retrieve sperm, or if the urologists don't retrieve sperm after 2 attempts, the likelihood of retrieving sperm will go down. And remember, basically, Louise, it depends on what kind of procedure was done the first time. So, yeah. If the surgeon end up doing a regular TZ, they might elect to say, okay, next time we want to make sure that there's a microscope, and let us do a micro TZ. Sometimes if it is recurrent operation to the testes will cause fibrosis, and that's why the likelihood of finding sperm after quite few attempts will start dropping. But most of the time, most men are given the option by the urologist to have it up to twice. To see, again, it depends on the surgical technique used as well.
And in terms of the effects and the recovery for the man after the surgery, is it common that the man's testosterone might lower following these interventions?
That's right. Remember that we always look at the testes as producing sperm only, but similar to the ovary, where the ovary produce eggs and estrogen, the testes, basically, on the other hand, produce sperm and testosterone. And obviously, like any organ in the body where it's subject to surgical procedures, because even in the best hands, you might be, decreasing the blood supply a little bit to the testes. Some cells might rise. So there might be a transient drop in the testosterone before that can pick up later on. But you are right. Yes, it takes, the recovery in general after those procedures is relatively fast. But again, men will suffer with some discomfort and pain for quite a few days, obviously.
Mm-hmm. Yeah, of course. Thank you for that. There have been lots of questions coming in, so I'm just going to pull them up now. Let's see. So, sorry, just trying to work through them.
Fine.
Someone's husband has tested high in oxidative stress. What can he do to this?
That is the oxidative stress. This is what we mentioned, is when there are lots of oxygen-free radicals in the sperm, that might have a direct or an indirect effect on sperm DNA fragmentation. So a key factor when we have high oxidative stress is lifestyle changes. And that includes weight loss, exercise, the vitamins and the antioxidants that we mentioned about before. And in some men, it will be quite important to do a physical examination to check if there's any cause for the elevated oxidative stress. By cause, I mean like a varicocele, which is like a varicose vein, but is the varicose veins of the testes. And sometimes operating on those varicosities might improve the outcome.
Brilliant, thank you. And can you still do IVF with zero morphology?
With zero morphology, remember that, again, when it comes, you will find sometimes it's very common for men to do a semen analysis in different labs, and sometimes a lab reports 1%, another lab reports 2%. It depends what you define as normal, I have to admit, because you can see in some reports they mention we have used the strict Kruger criteria, which, as the name implies, is quite strict in what's defining as normal and what's abnormal. The answer is that yes, we can achieve a pregnancy if we manage to find, because in general, most of the time, if we look enough under the microscope, or when the embryologists look enough under the microscope and give it a little bit of time looking around, in most, I wouldn't say in every case, but in most of the cases, we should be able, out of millions of sperm, to find, what, 10 or 7 or 8 of normal sperm to be used for egg insemination.
Okay, that's good to know. Thank you. And what about IVF versus ICSI for male factor fertility treatment?
I remember when it comes to IVF, to simplify matter, IVF is when we mix sperm and eggs and we allow nature's selection to choose the best sperm to fertilize the eggs, while ICSI, which stands for intracytoplasmic sperm injection, we take the sperm and inject it inside the egg. We always try to be obviously as close to nature as possible. It's not natural, but as close to nature in the sense that if there is a normal semen parameter, we always prefer IVF. ICSI is used if we have a very low sperm count, if we have mainly a problem with the motility or the normal forms, if the man has a normal semen count, but previous treatment resulted in a low fertilization rate, or in men whom we retrieve sperm surgically. So by definition, when we use surgically retrieved sperm, it has to be ICSI.
Okay. Thank you. Someone has said that their husband is icing his testicles an hour an evening. Would you say that's a good idea to help his sperm?
I remember that, there's lots of this advice. Sometimes I have that ask. It's present lots of time on the internet as well. And I remember, for any advice to be given, we must have proper scientific evidence for us to, offer this advice routinely for everyone. The answer, obviously, that we would like the testes to be at 3 to 4 degrees lower, but not necessarily just to, subject the testicles to icing and so on. So to ice. What I would suggest is try to decrease anything that increases testicular temperature rather than cooling the testes, if that makes sense.
It does make sense. Thank you. And with a man with 586 million sperm count, but 2% morphology, would you still say that there's a chance of natural conception?
That's true, yes. Natural conception. Remember that most of the time we have to speak scientifically and properly is that we know how to interpret these semen parameters in the context of infertility. There might be millions, and there are millions, if not billions, of men fathering children with parameters that are lower because it's basically studies set what is normal or not. And if we have 2% of 500 and something million, obviously, all what it takes is one normal sperm to inseminate. And having said that, what's more important, normal forms is very important when it comes to natural conception, but what's more important is the motility. Because just the sperm has to swim all the way and reach the tube in order to meet the egg. So obviously, while normal forms are important, motility is more important. But going back to the question, the answer is yes.
Okay, great. Thank you very much. And someone has said that they've sadly had 4 miscarriages with IVF. They said they got 2 to 3 cells every time, I presume embryos. Should they continue? Doctors say I'd be better to try with donor embryos, but we still want to try with my own. That's not so much male factor, I don't believe.
Remember, it's a combination. Just to answer a little bit of the question is that she needs obviously some quite detailed investigation at this stage. And when I say investigation, means investigating both sides. So investigating eggs, investigating sperm. To see, we always try our best to treat couple with their own gametes. But if we think that no, we cannot treat, we just say, okay, the only other option is egg and or sperm donation.
Okay, thank you. And someone here who also has a husband with azoospermia, and they're just awaiting the results to see if it's obstructive or non-obstructive. We just read somewhere that 85% of non-obstructive is undiagnosed. Is that correct?
That's true. That's true. So non-obstructive azoospermia, just to because there might be some people joining us today who don't know just to give just general explanation. So if we have azoospermia or no sperm in the ejaculate, it's either a problem with production, which is the non-obstructive azoospermia, or the testis is functioning properly, but there's an obstructive way, so the sperm is not reaching to the outside. Most of the time when we have a non-obstructive azoospermia, which means testicular problem, we try to fish for reasons. And reasons might include chromosomal abnormalities, might mean Y chromosome deletion. Unfortunately, in most of the cases, we don't find a reason. But not finding a reason, it might be secondary to medications, it might be secondary to lots of other things. But if we don't find the reason, that doesn't mean that there's no reason. That means we don't know the reason, at least at this point in time.
Okay, thank you very much. I'm just trying to see more other ones around male fertility. Sorry, some about egg quality. Would you recommend acupuncture for low sperm count if we're thinking about the holistic lifestyle changes?
That's a good question. Actually, at one point in time, I was quite interested in that. I was just interested because, lots of my patients come, they ask about acupuncture, they ask about reflexology, they ask about yoga, they ask about all of this holistic approach. So actually, I had the curiosity. I did a course. I became a member of the British Medical Acupuncture Society, which more or less believes in the Western approach of acupuncture. When it comes to acupuncture, there's a very strong belief because we want to know how acupuncture works, if it is going to work. And the answer is most probably it works by increasing the good hormones, which is the morphines, the endorphins. And this is indirectly, most probably works by decreasing stress levels. Because in the equation of infertility, we always forget about stress. Mm-hmm. And stress is a major factor for both male factor and female factor in fertility. So I would say I'm definitely in the Western approach. I'm not with actually Chinese herbs. But when it comes to acupuncture, if I always tell whether the ladies or men, if it is decreasing your stress level, do it. If it is not decreasing your stress levels, then it's unlikely to be that beneficial.
That's great advice. Thank you. And someone's asked about marijuana. Does that affect sperm the same way as cigarettes do?
That's true, if not more, actually. Because remember, any form of recreational drugs, whether marijuana or other forms of basically, we know that anything that crosses the cell membrane will cause toxicity in the sperm genetic material. And that's why it's a very common question for us to ask, do you smoke? Do you smoke cigarettes? Do you smoke marijuana? Do you use recreational drugs? How much alcohol? So all of that will definitely affect sperm and egg quality. So the answer is yes. Obviously, stopping will help outcome and sperm quality, because we go back to sperm quality. A gentleman smoking marijuana might have a 50 million sperm count, but that doesn't mean that the 50 million sperm count are all good in quality.
And how long does it take to change the sperm? Did you say 3 months?
That's right. That's right. To start, in general, we should start seeing some difference relatively quickly, but to see a proper difference, I think 3 months is a valid time because of the time scale of the cycle of spermatogenesis.
Right. And that's pretty similar to eggs, is it not?
Remember, with eggs, the story is a little bit different. When it comes, obviously, in 3 months, we will start seeing changes when it comes to, lifestyle changes on egg quality. But ladies, just off the record, is that ladies are born with a specific number of eggs that is not going to increase. So in general, a lady that ovulates an egg today is an egg that was created when she was born. So whatever happened throughout her life will affect egg quality. But obviously, you are right, Louise, that the last 3 months are quite important. But it's not, what I'm trying to say is it's not only those 3 months when it comes to that.
Yeah, I understand. Thank you. And someone's husband is about to go through, well, they're about to do IVF, and they've got their micro-TZ scheduled for March. Do you suggest getting the COVID vaccine?
A very good question when it comes to the COVID vaccine. The advice has been changing quite quickly when it comes to the COVID vaccine. And we keep on asking our patients to keep an eye on the Royal College of Obstetrics and Gynecology. At the moment, the advice regarding the COVID vaccine is that people who are taking the COVID vaccine, there is no need to delay their fertility treatment. And even COVID vaccine during pregnancy is so far, obviously we lack the evidence, but the Royal College say that people who are at risk, obviously not everyone, people who are at risk can still take the vaccine. So going back to the sperm question is that if his turn is to take the vaccine and he's called to have the vaccine, yes, take the vaccine. Don't delay taking the vaccine to have fertility treatment.
Fantastic. Thank you very much for that. I'm just going to see how many more questions we have. I'm aware of your time.
That's fine. I'm happy. Just whatever, I'm happy. I hope I'm
We'll
answering.
do a couple more, and then I just want to talk a little bit about your offering in our new initiative, and also the article that you've just written for us, which people should check out. So, what about quite heavy cycling for someone with, and I'm going to try and say this correctly, teratospermia that's been classed as clinically insignificant?
Okay, so remember that when it comes to cycling again, specifically right now in the pandemic, we have to always make sure that we are answering things in current, because we are advising these days people just to avoid public transport and keep active and cycle and run. And so it always depends on how long do people cycle, because cycling will indirectly affect increasing testicular temperature, and increasing testicular temperature might affect the sperm. And regarding those, medical terms, teratosospermia, everything which starts with a terato is a problem with the normal forms. So a teratospermia or a teratosospermia is problem with normal forms. Along, not only, I would say, not stopping cycling will improve teratosospermia on its own, but as part of improving your general health and lifestyle will most probably improve outcome as well. That's right. In addition to that teratosospermia, there's another thing which is called asthenospermia. Everything which is astheno is movement. So that's why when you look at the same, it helps most probably improving both, although I agree clinical studies don't make it black or white, because it's part of several parameters.
Okay,
that
really
needs to be improved.
Thank you. I hope that's answered the question.
So.
And people have said how informative it is, so thank you. And how, when doing ICSI, can you be sure that the embryologist is going to select the best sperm? Can they make mistakes when it comes to sperm selection?
It's an it's an excellent question. Remember that when you say what is a normal sperm, it depends how much I'm magnifying to see the sperm. With ICSI, you mainly look at the sperm, you magnify to a specific level where you are looking at the head of the sperm, the middle piece, and the flagella, which is the tail of the sperm. So obviously the embryologist will try to make sure that they are choosing the most normal looking sperm as much as possible. Can they choose a sperm that might still be abnormal? The answer could be, and that's why there's more talks these days about something which I'm going to come across when it comes to the treatment of male factor infertility, called IMSI. IMSI is a form of ICSI. So we are still taking the sperm and injecting it inside the egg. But the M stands for morphologically selected sperm. So it's a specific form of lens or microscope that will magnify the sperm further to make sure that we are excluding. This will help us in looking inside the cell. So this will help the embryologist in excluding the sperm that have vacuoles, which are the tiny bags of fluid in the head of the sperm. Again, why this technique did not replace ICSI, it's a very common question. So if I have the facility to choose the better looking sperm, why I still use a technique that I choose any form of sperm? It's a very common question that we have asked. Remember that IMSI is still not an evidence-based treatment. So it's not in the guidelines. So it's not in the routine guidelines. Yet some studies so far published in the medical literature say that it might have benefit in mainly ladies with recurrent miscarriages, in men with elevated DNA fragmentation. So I answered that as part of the question, is that can ICSI miss the sum of the sperm that's normal? Yes, it can. It depends if we are saying what is abnormal is inside the cells. And this can be surpassed by doing IMSI. Yet IMSI will only most probably help in those two subcategories that I mentioned because of the lack of evidence to support its routine use.
Fantastic. Thank you very much. That's very thorough. We do have more questions. What I would suggest, because they're just coming through and we've been speaking for a while, perhaps, if everyone heads to the link in the bio, then you can read an article which CRGH have just written for Fertility Help Hub, all about how you operate, COVID, the patients you've seen, and how you've welcomed 12,000 babies into the world, which is incredible. And also that you're giving our readers free mini consults. So if anyone wants a free mini consult with Dr. Saab or the team, then please go to the link in the bio right now on Fertility Help Hub. It will take you to this wonderful article that they have written for us, and you'll be able to connect with them through that. So it's a fantastic opportunity. Thank you so much for that. Is there anything else that you wanted to say?
No, I want definitely to thank you, Albiz, on shedding the light on basically on fertility in general and specifically today about male infertility, because that's really something very, very important that we keep on dismissing as clinicians. And I repeat, sometimes I hope I answered as much questions as possible, but I cannot agree more. Sometimes if a couple or single men, single ladies, couple would like to discuss the medical history specifically, I'll be delighted, whether myself or, as you mentioned, the team, to discuss in a mini consultation what kind of tailored treatment we offer for them at CRGH. And then basically based on that, they can reflect on the options that we discussed, and we are happy to support them in their fertility journey, and we wish them all the best, whether with us or with anyone else.
Brilliant. And the wonderful CRGH are offering a free cycle of IVF in our global initiative against COVID. So if you've missed this and you would like to apply for this opportunity, again, head to the fertilityhelphub.com website where you can find out more and apply. So thank you so much, Dr. Saab. Thank you everyone for joining. Apologies for my coughing fits. I'm struggling today. But I
apologies for my delay as well.
I appreciate your patience and look forward to speaking to you soon. And everyone check out that article. The link's in the bio. So thank you, everyone, and have a good evening.
Thank you.
Okay. Bye-bye. Bye.